1 minute. I need to welcome my serious face. Nicolas, I've got a question for you. I've sent you an email. I just wanted to see if it kind of got through to you. It might have ended up in spam. There's a chance.
No, I don't think I got any.
No? Maybe you can have a look again, just also of interest, because there was the email listed by the Resuscitation Council as like when we had the email for the faculty, I just replied to that link. And then because I tried to message you on ResearchGate and it kept crashing. And then after my third attempt, I thought I'm going to spam you with random half messages. So I stopped because it was related to potential questions to this session. Yeah. But now it's irrelevant anymore.
Yeah. No, I'm sorry, I didn't get any. I'm going to look because many important mails get up in the spam recently. And there must have been some kind of, problem there.
Now from them.
Currently live.
Yeah. Hello, everyone.
Well, good evening, everybody. Welcome to this free poster session of post-resuscitation care. My name is Nicholas Nicolaou. I'm a cardiologist and intensivist working in Athens, Greece. And it's my honor to moderate this session together with my co-chairs, Anna Bickham from Germany and Michael Smith from UK. And so without further delay, I would like to introduce Nico Acker from Germany to give his lecture and present the work of his group on incidence and predictors of delirium after cardiac arrest.
Thank you very much for this introduction. My name is Nico Eicher. I'm a medical student from Germany, and our group recognized that there are really few data on delirium, especially in internal medicine patients. And so we decided to focus our research on this kind of patients. And I think we could start the video right away. Good afternoon, ladies and gentlemen, dear colleagues. First of all, thank you for inviting me to speak on this online session. I am really honored to present you the work of our team on behalf of the other authors. I work in a big cardiac arrest center in Freiburg in Germany, and we saw that many patients who got resuscitated develop a delirium on our intensive care unit. So we did a retrospective registry about delirium on intensive care units after cardiac arrest. Now, there are two major studies about the incidence of delirium. Pollock et al. Had an incidence of 100% delirium in resuscitated patients while using the CAM-ICU to detect delirium. Kaiser et al., they had an incidence of 30%, and they did a psychiatric consultation on each patient to diagnose delirium. So we asked ourselves, what is the incidence of delirium on our intensive care unit for patients after cardiopulmonary resuscitations, while we used the NuDisc to detect delirium. So we did a retrospective manual case-by-case review of all patients on our intensive care unit in 2019. We used the nursing delirium screening scale to detect delirium. It is routinely taken as part of daily care 3 times a day by specially trained intensive care nurses. All in all, we analyzed 1,099 patients, and for this abstract we included 93 patients. Our population had an average age of 67 years, and about a third of them were female. A bit more than half of them had a shockable rhythm initially, and the average duration between cardiac arrest and ROSC was about 17 minutes. So how was the outcome of our patients? 84.9% of our patients who had been successfully extubated had delirium, and the delirium onset after this extubation was already after half a day. The duration of the delirium in our patients was about 4 days. Furthermore, we could show that delirium is associated with a longer ICU stay. Let me explain you this graph real quick. Here on the y-axis, we have the fraction of patients being treated on the intensive care unit. And on the other axis, we have the day after the cardiac arrest. Now, the green line are the non-delirious patients. They had an average ICU stay of 2.5 days. Now, the red line, the delirious patient, they had an average duration of treatment on intensive care units of almost 10 days, so almost more than 7 days more than the non-delirious group. So, to conclude, we could determine an incidence of 84.9% delirium in resuscitated patients using the NUDISC score. Furthermore, we could show that delirium is associated significantly with a longer intensive care unit stay. Our future work will focus now on possible predictors and adjustable risk factors for delirium, aiming to improve the treatment and the outcome of delirious patients in intensive care medicine. Thank you for your attention and stay healthy.
So thank you very much, Dr. Acker. So as far as I can see, there are no questions from the audience. Anyway, I think it's a very important topic. I mean, delirium in the intensive care can be a nightmare for doctors and particularly those on night shifts. But the numbers you presented of delirium of more than 80%, I mean, it isn't so much close to common perception, at least to my perception. And I would like to know, was it clinically significant in your patients? Did you have to have a psychiatric consultation or give medication to control those? Or it was just minor cases where, I mean, good nurse treatment and things like that might work? What is your impression on this?
Right. So it was a good mixture, I think. So there were really severe patients who had NUDISC scores up to 7, 8. So really hyperactive patients throwing things at nurses, pulling out their catheters. But there are also the hypoactive deliriums where the patients really just lay in their bed or disorientated. So I don't know if comparing them by medical or pharmacological treatment makes so much sense, because you have to differ between hypoactive, hyperactive, and mixed delirium, right?
Yeah, and to be fair, to add to this point is that hypoactive is severely underdetected. Your population age is quite young. You've got 67 years of age as an average, actually, which means plus minus you're going down to potentially patients in their 50s, which is very significant. Those are patients which might be of working in the working age, which means there might be individual of higher cognitive function where the difference in the fluctuation might be quite significant and fast within the days and the regimes. And it's terrifying to see that the 80% rate is prevalent in those cases. have you had a subgroup analysis of the causation of cardiac arrest correlating to the prevalence of delirium? Because if you've got potential prior cognitive dysfunction or cerebral strokes or whatever, or metabolic elements which obviously predispose you to that as well, did you have a further analysis of this?
Yeah, we analyzed by the cause of cardiac arrest, by hypoxia, by metabolic problems and electrolytical problems. And I think we also had myocardial infarction, but we didn't really see much difference between those causes of cardiac arrest.
Okay.
And we also didn't see a significant difference between the first rhythm in cardiac arrest. So that doesn't seem to be a big role.
Does your ITU have a prophylactic regime to prevent delirium in the first place in these patients?
It is quite hard to prevent delirium, really, but of course we have some strategies to try to prevent delirium, such as telling the patients, giving them orientation. We have clocks in each room. We have a calendar in each room, telling the patients at the beginning of every shift, every nurse should do that, to tell the patient, where are you? Why are you here? Which date have we? So prevention using orientation for the patient, giving them some background where they are, seems to be really a good prevention for delirium.
What about lighting and etc.? Nutrition?
We don't have specific prevention programs considering that, but there are programs that say, like, in the night there should be the lights out, there shouldn't be so much noise in the hallways, so patients can sleep well. You're right, that's a prevention strategy in delirium.
Okay, thank you.
So, okay, if there are no other questions, then thank you, Dr. Acker, and then let's move to the next speaker, which is Karin Steele from Sweden, and she's going to talk about health status and emotional distress among cardiac arrest survivors in relation to neurological outcome.
Yes, thank you very much. I'm Karin, and I'm a PhD student from Linköping University in Sweden. I'm also a registered nurse, and I previously worked at the cardiology department, and that's where I started my interest in these persons that I'm studying now. So please, you can start my video now. Dear audience, welcome to the presentation of the abstract Self-Reported Health Among Cardiac Arrest Survivors in Relation to Neurological Outcome. My name is Karin Steele, and I'm a PhD student at Department of Health, Medicine and Caring Science at Linköping University, Sweden. Cerebral Performance Categories, shortened as CPC, is widely used to assess functional status in cardiac arrest survivors. Despite that CPC 1 and 2 generally are defined as good neurological outcome, little is known about its association with patient-reported outcome measures. Therefore, the aim was to describe and compare self-reported health in cardiac arrest survivors with cerebral performance category score 1 and 2. This is a retrospective study with data collected from the nationwide Swedish Register of Cardiopulmonary Resuscitation. 2,058 cardiac arrest survivors were included in the study. Both in and out of hospital survivors were included. The survivors had to have their neurological status assessed with CPC at hospital discharge and at follow-up 3 to 6 months post-cardiac arrest. The survivors with the CPC 1 or 2 at the time at follow-up were included. The outcome measurements of self-reported health were Hospital Anxiety and Depression Scale and EQ-5D5 level. Data were analyzed using ordinal and linear regression models. The results showed that survivors with CPC1 and CPC2 together as a group using EQ5D5 level reported highest levels of health problems in pain and discomfort, followed by daily activities, mobility, anxiety and depression, and self-care. While using the Hospital Anxiety and Depression Scale, the mean symptom level was generally low. However, there was a great variation among the survivors. When using the cutoff score for HADS, symptoms of anxiety were reported by 14% of the survivors, and symptoms of depression were reported by 13% of the survivors. When the survivors with CPC1 and CPC2 were compared to each other, the survivors with CPC2 reported significantly poorer health in all dimensions measured by EQ5D5 level and higher symptom level of anxiety and depression measured by HADS. The significant difference remained also after adjustment for sex, age, place of cardiac arrest, etiology, and initial rhythm. So to conclude, despite that only survivors with traditionally seen a good neurological outcome, cerebral performance category score 1 and 2, were included in this study, a significant share of survivors reported poor health status and symptoms of anxiety and depression. In order to improve self-reported health for all survivors, it is of importance to screen for health problems also among survivors with good neurological outcome, particularly for those with CPC2. Thank you for listening.
So thank you very much. Very interesting data indeed. Sometimes we think we've done all when a patient gets out of the intensive care and the hospital, but then it seems now that still there are issues to solve. I mean, are there any questions from anyone? Because we have other researchers on this topic in the audience, I think. So if not, I'm just curious, was the result of yours driven by something that was unanimously present in all of your patients, or it was just a small group of patients that was driving the results? I mean, a few patients or a small percentage that might not be that well, and it is those patients that drive the results. Or was it something that was, obvious among all patients of yours?
Are you referring to how many patients that we were studying that having the CPC2?
No, I mean, how many of those with CPC2 had these problems you have mentioned? Was it something that was quite common among them, or?
We did see, I hope I understand your question now, but we did see a significance between the groups. So the CPC, the persons with the CPC2 score had a significantly worse health status than the CPC group 1. I'm not sure if I answered your question.
Yeah, no, my question was actually whether in the group with CPC2, was there problems that were equally distributed among, equally common among all your patients, or was some kind of subgroup of 10 or 14% of whatever that had their problems, and this was the group that was leading your results?
No, it was, I'm not sure if I can answer that question.
Okay. No problem. Maybe in English that.
I'm sorry.
Difficult for you to answer. So, and another thing that I'm curious about is, was there any sort of control group? Because I mean, these quality of life measures that you have used, self-reported quality of life measures, differ among age groups and, you know, are not the same for all. Did you compare this, your patients, with some control group from population?
No, we haven't compared to a control group, no. We were really interested in seeing if this group, as we still refer to a good outcome, if there is variation in between those good outcomes. But we haven't used the control group, no.
Karen, I've got another question leading to this. Basically, the depression anxiety elements also overlap with PICS, so post-intensive care syndrome, as well as inflammatory elements after cardiac arrest, due to the metabolic changes also in the brain, right? So how can you differentiate between the anxiety, depression related to cardiac arrest rather than the actual stay, like the post-traumatic element of intensive care treatment, which is very critical to a lot of patients, kind of torn out of their normal surrounding? Because severe, for example, like there's a lot of studies showing that severe PTSD or severe anxiety and depression correlate with immunosuppressive elements as well. Partially even mimicking immunosuppressive disease, even though it's not immunologically showable or detectable.
Is your question if we can be sure that this is due to the cardiac arrest, or is it?
Yeah, or due to in general, like the post element of intensive care treatment itself, because it's hard probably to discriminate between the two.
We couldn't say exactly what is actually the cause, but we do see that that it could be the cause that it's the cardiac arrest, and it could also be the cause that after intensive care, or several different factors. But we do see that there is anxiety and depression problems within these groups.
Are you planning to implement like a draft for white paper for service improvement in terms of, I mean, you've screened for them now, to once you've detected them, basically to have a safety net, because normally psychiatric support in or out of hospital is something which is poorly done in every country, more or less, due to the waiting times and the complexity of it, because it's significant, isn't it, due to they adhere worse to the treatment plans after out or inpatient as well, and have subsequent poor outcomes.
Hopefully this can in the future also lead to that we do screen these, or actually all patients for these potential problems, because it is like you say, it's not always a perfect follow-up of these survivors, and it could be much better, and we do need to pay more attention to this group.
Okay, thank you.
Thank you.
We also have a question on the Slido from Jess, who has said, what do you think is the next step in improving neurological outcomes in survivors? Do you think a screening program such as what you've just mentioned would be the best way to do that?
To improve the neurological outcome?
Yeah. Or sort of long-term neurological outcomes. So
yeah,
that can sort of include patient self-reported. Yeah. To improve the outcome, I'm not sure, but it's yeah, in the few further down the road, yeah, if we can find them and screen for them, if they do have health problems, we can give them proper care for their problems, and in the end, that's gonna hopefully help them. Yeah, so it's very important to actually screen these and get a hold of these, or say to direct them into the right care, so they do get the treatment if that's needed. It's very important. Wonderful, thank you.
Thank you.
So thank you very much indeed. So Michael, shall you go on with the next two speakers, please?
That's absolutely fine. So our next speaker is Erik Blennow Nordstrom, who's going to be speaking about the interactions between post-cardiac arrest outcome measures as an post hoc analysis of the TTM trial. So would you, Eric, like to introduce yourself?
I think you are muted.
It's very, very quiet, Eric.
Oh, sorry. I don't know what to do.
Now, yeah.
Sorry. Better now?
Yeah, you can start.
Great, thank you. Sorry for the mess. And thank you so much for your patience. I'm a PhD student and a psychologist at Skåne University Hospital and Lund University Center of Cardiac Arrest, also in Sweden. And my clinical work is in neuro rehab with outpatient acquired brain injury patients, such as cardiac arrest survivors. So I'm interested in finding valid and reliable follow-up models for outcome and to offer adequate support for survivors. And now you may start the presentation. Interactions between post-cardiac arrest outcome measures, a post-hoc analysis of the TTM trial. The latest European guidelines on post-resuscitation care recommend a neurocognitive screening on all cardiac arrest survivors. Also, outcome could be reported from 4 different perspectives: clinician reports, performance-based measures, patient reports, and informant reports. However, these outcome perspectives do not necessarily overlap. There is evidence of potential overreports of subjective cognitive impairments in other studies of acquired brain injuries, even when objective cognitive impairment measured by performance-based tests is absent. This could be due to impaired insight, fatigue, or emotional problems rather than cognitive impairment. The aim of the current study was to explore the associations between the 4 different outcome perspectives, that is, clinician-reported, performance-based, patient-reported, and observer-reported outcome in a cohort of out-of-hospital cardiac arrest survivors. This was an explorative post-hoc study of survivor data from the TTM trial. We used structured face-to-face outcome session data at 180 days after the out-of-hospital cardiac arrest. With the clinician-reported measures of CPC and MRS, the performance-based measure MMSE, the patient-reported measure TSQ, and the observer-reported measure IQ code CA. We tested the associations between the full-scale outcome instruments using Spearman's correlations, reported in accordance with Cohen's guidelines. At 180 days after the cardiac arrest, there were 486 eligible survivors, with data from the CPC, MRS, and at least one of the other instruments on 457, that is 94% of the survivors. And this was our chosen study population. A brief glance at the demographics: the median age was 62 and a majority were male. The patient scores on the outcome instruments in this study were the CPC score median score of 1, the MRS median score was also 1, the MMSE median score was 29 out of 30, and the IQ code CA median score was 3.08. And here is a correlation matrix calculated with Spearman's row. The clinician-reported CPC and MRS were strongly associated to each other, 0.63. There were strong associations when comparing the CPC with a performance-based MMSE, minus 0.53, and the observer-reported IQ code CA, 0.5, as well as a moderate association between the CPC and the patient-reported TSQ, minus 0.33. Associations between the patient-reported TSQ and the performance-based MMSE were small, 0.19. So, we found associations between all outcome perspectives. The clinician-reported CPC and MRS overlap substantially but are not perfectly correlated. More recently, the MRS has been recommended by the COSCA initiative in favor of the CPC due to the MRS's several categories and ability to capture milder problems. Furthermore, ceiling effects may be a shared trait between the CPC and MMSE. The strong correlation between clinician-reported and observer-reported outcome could be due to the presence of an independent rater in both perspectives. And as clinician reports correlate more strongly with the observer report than the patient report, this suggests that an informant report could add valuable information when assessing outcome after cardiac arrest. The weak association between performance-based and patient-reported outcome may reflect impaired insight in some patients, and this is in line with discrepancies observed using other instruments following other acquired brain injury. We found that all perspectives are associated with each other in this large sample of out-of-hospital cardiac arrest survivors, correlations ranging from small to strong depending on the instrument, and this suggests that all of these perspectives may be useful when assessing neurocognitive outcome after cardiac arrest. Thank you very much for your attention.
Hi.
That was very interesting. Thank you very much. One question that I wanted to ask to start is about the informant reporting that you talked about. Is this something that where you work is commonly being done? And if not, how do you think it could be incorporated into clinical practice?
Thank you very much for the question. Yes, we do try to use informant reports when working clinically with cardiac arrest survivors and caregivers as well. It could be used during interviews and by more standardized measures such as the IQ code that we use here. And my opinion is that it is a valid tool and it can give you sort of an indication of whether there is any memory issues or other cognitive problems after the cardiac arrest. And that's the pro of this measure as in comparison with, for example, the MMSE, which gives no indication of whether this situation is new from the cardiac arrest on, so to speak.
That's a very good point. Thank you. There are no questions on the Slido at the moment, but do we have any other questions from the other moderators?
I just wanted, it's a comment/question. You know, every score and every measurement is, every score is only as good as its content measured. So Michael and I talked about this prior to the session when we watched your video, and it basically, our thoughts were that often we have a younger population which isn't well captured in those scores of high functioning individuals like an academic, etc., which by those tests won't be detected as dysfunctional, but due to their normal functioning level prior to the arrest or the event will be significantly, there will be significant discrepancy, and it will be significantly affecting them in their day-to-day life because they will notice the difference. So do you think you might be able to develop or look into scores actually for this patient group, which might be small, but it's very significant because you're trying to get these people back to their working kind of quality of life, right?
That's a very good point. Thank you for that. And I also believe that you won't be able to detect minor discrepancies, cognitive dysfunction in this subgroup. And this subgroup will need more careful observation. And we do need to use our clinical vision, so to speak, to be able to capture even those milder problems that might not be able to be captured by, for instance, the MMSE or by very simple screening measures that we do use. We can be better by using other instruments, such as the MoCA, for instance, but we also would need to be very careful and guide even the slightest indication of one of those perspectives that I talked about, one of those perspectives, for instance, just to send to a further referral, for example, to neuropsychological services with more sensitive instruments.
I have to unmute. Thank you very much. Yeah, I completely agree with you. Good. Michael, due to the time, should we move on to the next speaker? Because I think there's no other questions.
Yeah, that's absolutely fine. So our next speaker is going to be Alexis Steinberg, who is talking about expert mental models for predicting outcomes after cardiac arrest. So Alexis, would you like to introduce yourself?
Yep. So I am originally from Canada, but working at the University of Pittsburgh. I am both a neurologist and an intensivist, so work in neurocritical care and medical ICU. My overall research interest is related to physician decision-making regarding neuroprognostication after all acute brain injury, but a specific focus on post-cardiac arrest. This project is a qualitative project, so very different methodology, so much more of hypothesis generating. And so you can play the video. Hi, my name is Alexis Steinberg, and I am a neurocritical care attending at the University of Pittsburgh. The title of my talk is Experts Model for Outcome Prediction After Cardiac Arrest. As you know, neurologic prognostication after cardiac arrest is complex and challenging. In order to understand this better, we developed this research project. The objective of this project was to develop models to describe expert physicians' approach to formulating a prognosis after cardiac arrest. The methodology of this project is qualitative in nature. We initially created a preliminary model based on AHA and ERC guidelines. We then created and performed interviews based on this model that had open-ended questions in order to probe experts' approaches to formulation of prognostication after cardiac arrest. Initially, we performed pilot interviews with 5 local physicians at the University of Pittsburgh who all partake in our post-cardiac arrest consult service. After initial pilot interviews, we used a reiterative process to refine the baseline model, our interview structure, and our codebook. We then perform interviews with experts internationally. The median length of time of these interviews was about 45 minutes. Myself and another person double-coded each interview. We initially used deductive methodology to code the interviews into higher level and subsidiary nodes, and then an inductive methodology to further alter the model. We performed a total of 18 interviews. Experts were defined based on meeting 3 different criteria. So they had to care for more than 150 post-arrest patients over their career, have more than 3 peer-reviewed publications in the last 3 years, and a leadership role in a multi-center post-arrest trial. Experts were mostly from Europe, so 2/3 were from Europe, another 1/3 from North America, and 1 from Australia. The main background specialty was critical care, followed by neurology, then emergency medicine, and cardiology. All experts cared for patients in an academic hospital, which would be considered academic in a U.S. hospital system. This is the result of our coding and our interviews. As you can see, the model is quite complex. There is a cycle of main things that happen in the middle, and then many different factors that affect this entire cycle. The weights of the arrows correspond to the cumulative frequency that these connections were mentioned in the interviews. So the thicker the arrows means that the connection of the 2 nodes were more frequently brought up through the entire process. When you take this complex model and take away all the less frequently mentioned nodes and just keep the more frequently mentioned connections, This is what you get. I want to point out that the goal of my interviews was really about how does the physician go from taking a patient to the process of formulating a prognosis. So the endpoint was right here. What we ended up finding was that physicians talked about this iterative process where they acquire some data, interpret data, formulate some type of prognosis with an uncertainty with that prognosis, and then either make a treatment decision or talk to the family about a treatment decision. And then if that doesn't happen, then they go back and acquire more data. There are different factors that play a role along this entire cycle or along different steps. For instance, there are physician factors, time, hospital factors, integration of information, and test features. These were the main ones that had a role on this entire cycle. Physician factors ended up having a lot of very unique and interesting themes. Many physicians talked about patients, so, being able to wait longer and being patient to see what happens. They talked a lot about intrinsic biases. They also talked about professional norms quite a bit, and their views on patient age came up very frequently. Themes related to this iterative process, so going from prognosis formulation to acquisition of data, came up quite a bit in various different interesting flavors. Many physicians talked about getting more tests, mostly in indeterminate scenarios, but it could be for a variety of other different reasons. They talked about not only getting tests, but getting more information by just waiting longer. So not necessarily that they had a test to get, that just they wanted to give more time. And then a very interesting last theme about getting uncertain tests when the case is indeterminate, most specifically an MRI. So this came up quite a bit. Overall, experts' approach to formulating prognosis after cardiac arrest is complex. Physicians consider many aspects beyond the diagnostic tools themselves. Most of these additional aspects are poorly researched and poorly characterized and are not discussed in current guidelines, very specifically physician factors. Thank you.
Morning.
Thank you very much for that. And it's very interesting to try and get a window into how the minds of these experts work. One question I have about this, though, is how can you be sure that what the experts are telling you they do is the thing that they actually do?
Right. So that's with all qualitative research, that's the big thing that you can't necessarily discern. And that's why qualitative research is really this paradigm shift of hypothesis generating and not necessarily proving all these things. So we'd have to go back and prove, that these things actually do occur. But the whole point of this project is actually to kind of for us to all think about, maybe there's stuff beyond the tests themselves that really play a role, and we should really start focusing on those. So it's much more of a hypothesis generating type of methodology.
Absolutely. And it seems like it was run extremely well. So well done for that. Do we have any other questions?
Looking at the digital request, there's nothing from the other audience. I have one more question because the hospital determining factor was quite big as well and had a strong correlation with, as you've mentioned, the thicker the errors are. So I know that you've interviewed European as well as state and quite international audience of clinicians. Now, we've talked privately about the training differences as well between state and Europe, for example, and the experience, and potentially what probably is one of the driving factors which makes me critical of clinical decisions sometimes from like the hospital point of view is that the people having cost calculations and the state, like in state element could be quite like the costs are higher or charged also to the patient, potentially driving also relatives' decision on some care. Can we, for some reason, also maybe look at the clinical decision differences in that, like cost factor on the clinicians overseas?
Yeah, there were all types of, so you can break down the hospital factors to all different types of themes that ended up coming up quite a bit. One was resource allocation and the resources. So if you don't have the availability of continuous EEG, obviously you can't get it. There's this whole idea of different societal norms that happen, especially that contrasts quite a bit in North America versus the UK, for instance, or in Helsinki, where a lot of the times we don't even admit certain types of patient populations to the ICU. So you're already prognosticating from the door, which that doesn't happen in the US. So there's all these little themes that do arise. Cost didn't come up as much as I thought it would, but some providers do bring up cost as kind of playing a role in their decision making. And the kind of scarcity of beds or anything like that also putting some pressure on kind of making decisions.
I guess scarcity of beds probably is more relevant to very small hospitals where the capacities are exceeded quite quickly, while I can only speak for the experience I've had in the UK or in Germany, that the ITU capacity in Germany is like one of the highest worldwide. So we kind of admit everyone that, it seems, to be honest, from like over 100 to 0. But cost, even though we have a lot of money in the health pot, and kind of treat excessively, the cost is a significant driving factor. And as a clinician, especially during training or junior attending, those don't play a significant role. But if you talk to the senior clinicians who then have a stronger managerial role, their decisions are more influenced by these costing elements. No?
Sorry, I just missed that last part.
I just said the senior clinicians have a stronger influence by cost elements, probably.
Yeah, potentially. And I've interviewed quite senior physicians, since these were all, people who read a lot of the guidelines. And cost came out actually a lot less than I thought it would, but I do feel that it probably plays a huge role.
Great, thank you very much. Good. There was a question anonymously placed. Are there any different findings between UA and Europe? I mean, we kind of touched on that, to be honest. Unless you want to add anything else, I would.
Yeah, so I'm starting to analyze. Yeah, so I'm starting to analyze a lot of that data right now, but there are huge differences. And so that will come out as a paper. But there's this huge focus on protocols and multidisciplinary teams in Europe that then people feel diminishes MD factors, and that theme doesn't come as much in North American interviews.
Brilliant, thank you very much. Michael, do you want to say anything, or I would move on to introduce the next speaker? Okay.
I'm happy to move over, yeah.
Okay, brilliant. So the next speaker is Filippo Annoni. He's from Belgium and will speak about the effect on cerebral metabolites of hypertonic sodium lactate infusion after resuscitation in experimental setting in a model basically after cardiac arrest.
Thank you very much. Good afternoon, everyone. It's a pleasure to be here. My name is Filippo Annoni. I work at the Erasmus University Hospital in Brussels, Belgium. I am an intensivist and internist. And what you're about to see is a pre-subset of data coming from the experimental part of my PhD, which focus mainly on the impact of hypertonic sodium lactate solutions in the populations of cardiac arrest, both experimentally and hopefully clinically. We may play the video. Thank you.
Good morning, my name is Filippo Annoni, and along with my colleagues, we have conducted a series of experiments investigating the impact of ketone bodies and hypertonic sodium lactate solutions on brain metabolites in swine models of cardiac arrest. This due to the importance that post-anoxic brain injuries have and the death of several patients in the post-resuscitation phase, and the particular different metabolic patterns within the brain cells. The properties that might be important of those solutions can be summed up into an alternative energetic substrate, as well as deep hyperosmolarity, and, in the case of hypertonic sodium lactate, the capability to mitigate the induced metabolic acidosis. There are plenty of literatures in both animals, healthy humans, and especially traumatic brain injuries that suggest that these solutions, hypertonic sodium lactate in particular, might be beneficial in these patients. The aim of our study was to investigate whether the administrations of different hyperosmolar solutions could modify the cerebral metabolites in the setting of post-resuscitation phase with the measurements due with a cerebral microdialysis catheter. To do so, we built it up an experimental model of 10 minutes untreated ventricular fibrillations followed by 5 minutes resuscitation phase and at 12 hours post-ROSC observations. We have included roughly 40 animals in the studies. One group was the controls, the yellow one. Then you would see the 2 oranges where the animals received hypertonic sodium lactate either during resuscitations or only in the 12 hours after ROSC, and one group, the green one, that received beta-hydroxybutyrate both during CPR and after in the resuscitation phases. To interpret our preliminary results, you have to consider that all the animals were treated with therapeutic hypothermia, and most of them, due to threshold achievements of the infusion safety limits, had a reductions of the lactate infusions rate in the last 6 hours. As you can clearly see, the groups pooled that received lactate infusions had higher arterial lactate levels, as well as the groups that received ketone bodies had a higher level of ketone bodies measured in the artery. The arterial pH, as expected, was much higher in the groups that received hypertonic sodium lactate compared to controls and ketone bodies. The cerebral glucose levels were not different between groups, despite a small difference in trends might have been seen at the very beginning, T0 as the baseline and 1 is 1 hour after the ROSC. The cerebral lactate infusions, a little bit more surprisingly, was also not different between groups, especially also considering the lactates groups compared to controls, as you can see on the right, maybe due to the decreasing lactate infusion speed. That is one of the possibility. The LPR ratio was not different also between the groups, despite, as you can see on the right, between the ones that received lactate over the study period and the control groups, in every single time point the LPR was lower in the groups that received lactate, but as you can also see, the values were almost normal in both groups. The lactate glucose ratios was nevertheless different, so the two difference we could not have observed by looking at single metabolites became a little bit more bigger here, and you can see that the difference was between the groups that received lactate infusion and the controls. Cerebral glycerol, strangely, was higher in the group that received ketone bodies compared to the others, and that might be due to 2 animals that might have had a bad prognosis if the experiment would have been conducted for a longer period. Cerebral glutamate, even more difficult to interpret, had shown in the groups a different trends, especially when you compared on the right the pooled controls versus the lactate. They have a completely different patterns of glutamate, extracellular glutamate, but that needs further confirmations. We have provided also EEG data, but we have not yet ready to present them. When we look at the arteriovenous difference of glucose and lactate, and in the next slide of the extraction ratio, it becomes clear that the positive difference and for glucose or lactate was differently distributed between groups. Probably in few animals that received lactate, the lactate in the artery was higher than the lactate in the venous, differently from the control groups, especially if we look at as an extraction ratios. As you can see for glucose on the right, the behavior of our interventional groups was way different compared to controls. I would like to thank you very much, and I'm open for a few questions. Thank you.
Okay, so I've just checked. There's no questions from the other audience. I'm happy to open also the question to the other colleagues of yours who've presented, obviously. If there's none, I would, as a clinician especially, because you obviously now have us much more an advantage and knowledge into modeling and testing basically in the model with these parameters. Can you see the information you've drawn and will draw in the future once you've completed your study, how that can translate into clinical practice as a clinician yourself?
Well, that's a very good question. It's actually those data will support a clinical study that has been granted by the European Society of Intensive Care Medicines with the clinical awards, research awards of last year. We believe, despite microdialysis does not measure metabolism, but measures metabolites, that those differences must be carefully analyzed and carefully interpreted. But nevertheless, what we are searching are indirect, let's say, data that can support the idea that giving lactate, whether because hyperosmolar or because used directly by brain cells, could alter the metabolism. Alone, the cerebral microdialysis cannot give these informations, but we have coupled this with way larger complete neuromonitoring settings on partial tensions of oxygen, ICP, and everything that concerns brain hemodynamics. And we hope that those signals goes all together in a specific direction.
So the clinical study which was granted, will be initiated in what population pool?
Well, it will be in post-cardiac arrest patients that will be randomized to receive either hypertonic sodium lactate or placebo, actually, as a phase 2.
Yeah, and will these patients be on like a neurosurgical, like a neurocritical care in terms of, because of that significant element of supervision with these intracranial probes, or how am I imagining this?
Well, there is already one group in Canada that have published in between 2017 and 2019 a series of patients that have the complete subset of neuromonitoring, which is showing somehow encouraging results. But we do not think that those two things might go on parallel, but not forcefully needs to merge, specifically because we do not expect to greatly improve PbTO2 by giving lactate. We have data in brain traumatic injuries that are not supporting those things. We don't see why we should forcefully go for that. But it's under evaluations because it can actually helpful to merge the two.
Okay, brilliant. Thank you very much. That's very interesting. I would move on because there's nothing else to, and we've got some time pressures actually, to our last speaker, Calypso Fay. She is a clinician, as I understand, from Freiburg in the south of Germany, and we'll be talking about biomarkers they have tested in the survivors on ECMO after cardiac arrest. Thank you.
Hello, my name is Calypso Fay and I belong to the working group of Dr. David Staudacher from the University Hospital in Freiburg in Germany. And I would like to present the research that we have been doing on biomarkers in the prognostication of patients who undergo extracorporeal life support system implantation. The purpose of our study was to identify biomarkers that could allow a prediction regarding the prognosis of ECLS patients, since the prognostication is generally a very complicated, complex matter in that patient collective. ECLS implantation is a very invasive treatment that triggers a very strong inflammatory response, which is why we decided to take a look at biomarkers that are related to inflammatory response and investigate if some of them correlate with the patient's outcome. We recruited a total of 18 patients undergoing ECLS implantation over 6 months from May 2019 to November 2019. We drew blood samples from each one of these patients at 5 different time points. The first one was directly at cannulation, then 12 hours following the cannulation, 24 hours, 48 and 72 hours. We then analyzed an array of 92 inflammation-related biomarkers in plasma and serum, including a majority of biomarkers that are not commonly used in clinical practice at the moment. And each one of those biomarkers was then tested for significant difference between survivors and patients who did not survive, right at the cannulation time and 12 hours later. Those that did show significant differences were then tested for significant differences between the two groups over the 5 time points. We identified 5 biomarkers that did show significantly different levels in survivors than in non-survivors. Here, these graphs show the levels of biomarkers over the time course with the 5 points where we drew the blood samples. The black curves represent the patients who did not survive, and the blue curves represent those who did survive. And these graphs show that interleukin-8 levels and interleukin-1 alpha levels were significantly higher in the patients who did not survive than in the ones who did. Whereas beta nerve growth factor, monocyte chemotactic protein 2, and interleukin-5, which is also known to be a chemotactic agent, had significantly higher level in patients who did survive than in those who did not. And those results suggest that especially chemotactic proteins could possibly correlate with the prognosis of extracorporeal life support system patients. Which is why for us the next steps in our investigation would be to run an analysis of leukocyte activation via flow cytometry, and also to conduct a follow-up interview via telephone with the patients who did survive 1 year after the extracorporeal life support system implantation, in order to assess the life quality that these patients now have. And yeah, we hope to be able to present those results to you at the next Resuscitation Congress. Thank you for your attention. Goodbye.
Thank you, Matt, for sharing this video. Calypso, I've got a question for you, because there's no digital questions sent in, unless someone else from the audience of our other presenters want to go ahead. No? Okay. So 92 markers is quite a significant amount. You've been obviously testing them extensively, and I've identified interesting trends. What is the clinician is interesting for me is, have you, because they haven't been listed with the other ones you've tested, what about NSE and lactate or fibrinogen levels, which also can be significantly predictive in these patients? Have they been tested and correlated? Because NSE has been validated, and so it would be interesting if in your test samples these show also the same trends as a support for the quality of these correlations you have identified.
Hello, just one thing. I just saw your message that I should introduce myself briefly. I haven't seen it before, which is why I hadn't my camera on before. Thank you for the question. We did analyze NSE and a lot of other markers that are related to inflammation in the body. And the 5 markers that we listed are the ones we found had a significant different level in survivors and in non-survivors over the first 3 days following the implantation of the ECLS. We first also ran a retrospective study regarding your question about lactate, where we found a significant difference in survivors compared to non-survivors. However, NSE did not appear to be significantly different in our study, which maybe also shows the limit of our study. That could be seen, for example, in the fact that we have a rather small group of patients on whom we conducted the study.
Okay, thank you. So you are planning on following them up after 1 year, which is roughly what time frame?
It would be, we're going to start it next month, because that would be 1 year following.
Okay, so from clinical experience, depending on the underlying cause of the cardiac arrest and the comorbidities prior to that, the mortality rate is still significantly high in the after 30 days or even after within the first 6 months post-arrest. So if you've had initially a small sample size, you probably will be dropping quite a lot of.
Excuse me, sorry.
It's all right. You could still be analyzing to correlate the cognitive dysfunction or quality of life to your markers. Would it, what number you're expecting to have dropped out actually from your prognostication? Is there a list already of patients you haven't been able to reach prior to the start now?
We haven't actually reached out yet to the patients because, as I said, like it's not the time yet where that phase of the study is starting. So I can't really say anything about that yet. But yeah, like we know that that's usually one limit of the follow-up, that you can't reach all the patients. And also, we don't know at this point how many of them are still alive.
Yeah. Okay. Good. We still, according to our technical moderator, we still officially have time up to 5:45. So we've been given extra time. So I'm happy to open it up to every other person in this group to exchange any more ideas or ask away. You've not got any digital questions coming up officially from the website. No one's trying to say anything. Do you want to add anything else you've not been able to share on the 5-minute presentation?
I don't. If there's no further question, I don't think so.
Good. Michael and Nikolaus, do you want to say anything else? Otherwise, from my side, I would thank everyone for presenting and all your hard work. It's great to see all the engagement and encouragement, and it's encouraging to see that, especially young researcher, so motivated and working in the field of cardiac arrest. Well done. Keep going.
Nothing else from me, but again, just well done and thank you to all of the speakers.
And stay healthy in COVID times. It's the last thing. Okay. All the best. Thank you.
Thank you.